This week on the BackTable Podcast.
For people going forward, I always say it was a life of inquiry, and we always are curious. And so all the fellows, as far as on a research level, it is hard work. But, Teddy Roosevelt said, doing hard work at work worth doing. And I think that we are really fortunate to be in a field where the work is worth doing for our patients, for each other, for our colleagues. And I think doing collaborative team science, which is, again, it takes a team. It's a village, we're just one side of many for most trials, just like you're running all those NRG and the green tea catechins. Everyone has to put their part in. And as a team, we're going to really make some progress, which we have in leaps and bounds in my 20-year career so far.
Hello, everyone, and welcome back to the BackTable Podcast, your source for all things urology. You can find all previous episodes of our podcast on iTunes, Spotify, and at backtable.com. Now, a quick word from our sponsor.
This discussion is brought to you by Veracyte, provider of the Decipher Prostate Genomic Classifier. Decipher Prostate is a test for patients with localized prostate cancer that can help personalize treatment. Every patient and their prostate cancer is unique, and Decipher Prostate can provide meaningful insight into the aggressiveness of each individual's patient's tumor. Because the Decipher score is derived solely from the genomic characteristics of the tumor, it provides information not available through already known clinical and pathologic factors. Decipher high-risk patients generally benefit from earlier or intensified treatment, while Decipher low-risk patients may be ideal candidates for monitoring or less overall treatment. Decipher Prostate is the most validated gene expression test in localized prostate cancer, with level 1 evidence in national clinical practice guidelines and more than 70 peer-reviewed publications, including more than 65,000 patients. Visit Veracyte.com/Decipher to learn more.
Now, back to the show. This is Aditya Bagrodia as your host this week, and I'm very excited to introduce our guest today, Dan Lin from University of Washington. Dan, how's it going today?
Great. Thanks so much. Thanks for having us.
Well, I am super excited, Dan. Literally as I was preparing for this, I was thinking to myself, I'm going to take advantage of this hour to pick his brain on everything PSA, prostate related. So I'm going to try to refrain from this turning into Joe Rogan, long format, 4-hour podcast, but bear with me. And I'm also super excited. This episode is going to be kicking off our partnership between BackTable and the SUO to try to get some content out there that's useful to our society and the community at large. So today we're going to be talking about active surveillance. You guys have done some tremendous work with your Canary pass data over there. And perhaps we could just start a little bit, Dan, but why don't you share what you guys have been up to, published recently this past summer in JAMA with respect to your cohort and what you found pertaining to active surveillance.
Sounds great. And first, again, I want to thank you and BackTable for this partnership with the SUO. I'm excited to have a formal collaboration. As you know, the SUO is trying to increase its breadth. We have a lot of collaborative things with other groups around the world, and BackTable was that one piece I really wanted to have an ongoing kind of enduring collaborative spirit with. And so this being the first podcast of many, I hope, in the coming years, with SUO members discussing topics that are really relevant for our society and the care of our patients. So I really, really appreciate it. To your question, I'll keep it brief. Canary has been around since 2007. So it was a donor that was in the Bay Area that wanted to get involved in prostate cancer early detection. And he came to us at the Hutch, myself and Pete Nelson, a molecular biology researcher, medical oncologist, and said, hey, I want to find prostate cancer earlier. I have friends that have had it. How can we do this? And at the time, I'll be honest, I said, we can find prostate cancer real well, like maybe too well, right? Find too much turtle on the block, low-grade cancers. But we need to find out what to do about that. So I'm going to propose to you to do an active surveillance trial to find biomarkers, to understand the natural history of the disease. Again, this is 2007. He said, I only got 2 requirements. You have to include Stanford, UCSF, has to be a West Coast effort to start with so we can be really nimble. And then now here we are 15, 17 years later. We've got 10 sites across North America, including UBC in British Columbia, and then, all the way across to Boston. We've now accrued, over 2,000 patients prospectively. There's a huge biobank, and they have a really kind of a steady schedule. So they're getting biopsies routinely, and we have this huge biobank, and it's been a really fun time. And it's kind of culminated, of course, in the JAMA article from this summer, but along the way, having a great time doing translational science and getting grants and trying to push the field forward. So that's kind of a thumbnail of how we started the whole process.
That's super cool. I recently had the good fortune of talking to Manny Menon about his involvement in robotic surgery globally and within urology. And there's a lot of similarities. There was a donor, the Batakuti family, that was interested in kind of moving the needle, and he teamed up with Michigan and some of the institutions there in Michigan, and here we are. Fantastic. So it's an amazing cohort. In my mind, there's 2 or 3 large prospective prostate cancer experiences. Canary Pass, of course, the UK, they do a pretty gangbusters job. The group at UCSF, and Vandy seems to stick out along with maybe music urology. This is not comprehensive, but some of the ones that I think are tremendous. And I think it is hard to talk about prostate cancer without diagnostics in some form or fashion. And let's just briefly, patients coming in, either they're being referred to you for an elevated PSA or they come with a diagnosis. Free PSA, density, secondary cancer screening tests, family history. At a high level, what are you intaking when you make a decision to do something to work up this PSA?
Sure. Yeah. I think I step back a little bit. I mean, we're fortunate in that because in our profession, of course, they're coming to us already with an elevated PSA. But if we step back and zoom out a little bit, even just PSA screening, and I had the pleasure of co-chairing the AUA guidelines for prostate cancer detection, and John Way was the chair, and that got released about a year ago. And that was really for screening and earlier. And what you're asking maybe is someone comes to me with an elevated PSA, but it's important to think about in screening, who to screen, when to screen. We actually, for the first time ever, now have some guidelines as far as higher risk groups, such as those of African descent or BRCA mutations. So we lower the age of starting the screening in those patients. We also lower the age in the average risk patient, so down to 45 to 50 instead of 55, like the USPSTF. Be that as it may, we also in those guidelines did have to address some of the issues which you just mentioned, which was at time of elevated PSA, do we do adjunctive testing? Do we do biomarkers and so forth? And the guidelines, again, I'll point everybody that way because I do think they represented the current state of the art, is that they're a bit cautious, particularly in the biopsy-naive population. So we decided, I think appropriately, to divide patients with elevated PSA into those that have never had a biopsy versus those that have had a previous negative biopsy, because we treat them differently, and the performance characteristics of the secondary tests are different depending on the two groups. So to give you an example, if you look at the high-level meta-analysis of even MRI for the diagnosis of significant prostate cancer, if you look at how it performs with a biopsy-naive versus a previous negative biopsy, it's different. In fact, in one of the meta-analysis, first author was Drost, D-R-O-S-T. There was a Cochrane review with it. It actually was not statistically significantly added benefit for detection of clinically significant cancer in a biopsy-naive population. MRI was not. The hazard ratio crossed 1. So we wonder about whether MRI should be required in a man that's never had a biopsy. And it performs much better in a previous negative biopsy. So I take those things into account. It's kind of a long-winded way of saying that there is kind of my own neural network. We did say that there are tools to use that take into account family history, previous biopsy, of course, free PSA if that's available, MRI, and so forth. And we list those in the guidelines and ask people to use them. Candidly, says, this is a time to kind of air out some of this. I get a little frustrated because there's, PCPT risk calculator, there's the PCBG, they give totally different results. There's the Sunnybrook, and which one do you use? And some of them have different criteria. And I sometimes show patients, I'll give you an example. I'll show patients their PCPT and their PCBG, and then I'll say the truth is probably in between because they're so disparate results, and it's frustrating. It is for the patients mostly. I live it, so I have to deal with that frustration. But all joking aside, I think that we do have to kind of take into account as many variables as we can. And one of the big ones is previous negative biopsy, as well as absolute value of PSA.
Yeah, and I mean, it is intriguing. It's such a rich discussion. And actually, I intend to bring some of these factors back into surveillance. Are you using them, density? Let's say they came in with a relatively high risk secondary cancer screening test, which is not baked into, I think, most surveillance platforms, but how is that all going to kind of interplay? All right, so I don't want to get derailed too much on what to do. Let's check a PSA and what to do with it. All right, so 2 scenarios. One, the patient had a biopsy, they're being referred to you, and let's perhaps try to focus on, like your paper, favorable risk prostate cancer. Of course, there's the patients that are sicker and infirm, competing morbidities that have high-risk prostate cancer. We say, hey, this is not gonna kill you. And maybe going back to the nomograms, I think you find the one that's going to help the patient feel kind of good about it in some form or fashion. Okay, so typical garden variety, elevated PSA, 6, 7, life expectancy, 15, 20 years. Your standard without over analyzing this. No crazy risk. Not everybody had prostate cancer. What's the typical kind of next step?
Yeah, and they're already diagnosed with favorable risk disease. Is that right?
No, in this case, are you getting an MRI and doing a targeted biopsy?
Yeah, I'm usually doing that. Although I will say, if they have a small prostate and by exam, and I feel like I can sample them very well, do I always get an MRI before the initial biopsy? I really don't. It kind of depends on the patient and sort of holistically looking at their PSA curves if they have multiple PSAs. And again, a smaller prostate, I feel like I'm going to sample that pretty well. And if I miss something, it's not going to be very big. All right, and I'll have an opportunity later. In general, now I will tell you, I have leaning more and more towards getting MRIs in most patients. I am. And there is something about a fusion targeted biopsy that I think gives us some more reassurance, even at that initial biopsy. So I'll go that way. I won't necessarily get a lot of patients come to me with free PSA because a lot of providers here know some of the value of that, particularly in the elevated PSA setting. So a lot of them already come with a % free PSA. But I don't always go down the road of getting other things, other serum or urine markers at this point in the biopsy-naive patient.
Okay. Biopsies, transperineal, transrectal, both case-specific?
Both somewhat case-specific and somewhat depending on the MRI. I mean, if there's an anterior lesion, as you know, I think we have a better access to it. You know, we had a targeted hire here, and Claire Delicaya came from Hopkins. We hired her specifically because she's really great at transperineal, and we're growing our experience in that. We just kicked off a micro ultrasound program. George Shade is our champion for that here. And so we have micro ultrasound as well as standard transrectal fusion biopsy. As you probably know, the AUA guidelines did come down and have a statement about transrectal versus transperineal. We won't get into that. You know, there's been this recent randomized clinical trial that was updated after the initial negative results. And then there's that multi-center randomized trial with Jim Hu and Ted Schaefer. And then there's Bedarmian's single center trial, and get into the whole thing. But the AUA, and even if the AUA today probably looked at that, we would look at it and say that either is okay. Then again, one needs antibiotics and maybe augmented antibiotics and the other doesn't, but we don't have to get into that now, but we do both.
Yeah, I mean, I do both, and I think there's real value in either setting. You know, maybe just one for me, large prostate base lesion, I would probably feel a little bit more comfortable with the transrectal, just knowing I can kind of get there without having to go through 3 inches of prostate.
Mm-hmm.
If it's at the apex or anterior, I think both go well. All right, so again, I'm gonna try to stay on pace. I told you, Dan, I'm gonna pick your brain about everything prostate. So generally speaking, it's going to be an MRI followed by a targeted biopsy. And then if they've come in with a previous biopsy, whether that's ultrasound-based or MRI ultrasound fused, that's going to be another scenario. So again, relatively healthy patient, nothing kind of extreme in terms of comorbidities, prostate symptoms. When you're intaking this patient, you alluded to family history, African-American ancestry. Let's start with the biopsy report. When you look at that with your fine-toothed comb and you're trying to assess, is this a good candidate for surveillance? What does that kind of look like?
Yeah, I mean, I think that on the easy answer is virtually any grade group 1 disease. I do. I'm at the same time, when I look at the totality of the patient and I look at what we know now, which I think is undervalued, is the predictive ability of a few patient factors in deeming future reclassification or higher grade disease. And you mentioned one of them earlier, which is completely undervalued, I think, although in part because we don't know how to use it, which is PSA density. I think that if you look at every series that's ever been published, Hopkins, UCSF, Canary, all of them, if you look at PSA density, and even Prius in Europe, PSA density is directly related to future reclassification, as is number of cores. So when we look at those two items, which again, they're undervalued because we don't know how to incorporate them into decision making, and I'm trying to work on that. Like, I'd love to have a risk we do have a risk calculator that's online. If you look at the Canary Pass online, you'll see a risk calculator whereby you can put those in, and it will spit out, if the patient was like a Canary patient, their chance of having a reclassification event at the next biopsy or in 4 years. And we're working to upgrade that. It's in motion. We gotta do better at the calculator. But I think that when I look at a patient and to deem them active surveillance, initially it's almost every grade group 1, with the proviso and the caveat that if they have a high PSA density or high number of cores, I'll just tell them, you can start with active surveillance, but you have a higher chance of us finding grade group 2 or higher in the next 5 years. That's just a fact. Otherwise, again, any grade group 1, we can get into grade group 2 later as far as candidacy. I don't know if you want to do that now, but if they are grade group 2, we look at other issues. So,
well, let's start with the grade group 1. I mean, I think it's easy enough, and sometimes for surveillance in general, struggle a little bit to convey this concept of, my first job, as I see it, is to help decrease the temperature in the room, diffuse the anxiety that comes along with the cancer diagnosis. And, the first 5 minutes are, you're going to be okay. This isn't pancreatic cancer or esophageal cancer. We're talking about decades if this ever misbehaves. But there's about a 50% chance over the next 10, 15 years we're going to have to do something. And, just kind of juxtaposing, we may stop calling this cancer to we may have to do something, it's a little bit tricky. And I think the NHS calculator is probably my go-to to try to sort that out. If we start out with, path A, surveillance, here's where we land. But maybe two things. How does that conversation go with grade group 1 disease? And are there scenarios where you're nervous with grade group 1 disease, PSA density, MRI, young patients, family history, genomic classifiers? If you could run through those, or are you nervous? And is there a case where if you've done the biopsy and you have grade group 1 disease, you would recommend the next step be treatment?
Yeah, very rarely. I mean, I can cut to the chase a little bit that I can tell you, just listening to how you were talking about diffusing the temperature in the room, disarming the cancer in a way, and telling them that there's a huge movement that's international that's trying to rename this not even cancer. So those are really reassuring things. So I completely agree. There are almost no grade group 1 patients that I say you have to have surgery. I just don't know of any. I really don't. At the same time, the one knee jerk that I had that went right through my mind immediately, which I've had, and I'm sure you've had too, is the patient that is just having crushing anxiety over it and maybe has a really bad family history. I've had a few men that I just saw one this morning. Dad died of prostate cancer. He has grade group 1 disease and it's crushing him. And he might eventually, despite the fact he goes through initial active surveillance and has no grade group 2 disease, he might eventually opt to just have treatment. That's the one that went through my mind immediately. And although all the other situations, I don't think there's anyone that I knee-jerk to say yes. Even the ones, and I run another study called Patrol. Canary actually has some funding for that too. And that's in carriers of BRCA variants. Okay, and it's a screening study. So we're doing lower PSA thresholds and MRIs and some other cool things. And it's multi-center, MGH and Northwestern and Penn and us and City Hope. We're having a really fun time. We're going to do this study called Patrol for carriers who are unaffected. However, in that study, I've diagnosed a lot of men with prostate cancer. Grade group 1, they're in their 40s. They have a BRCA2 variant. They know what that means. In those patients, sure, we pause a little bit and say, it's been associated with higher grade disease. This might be just a harbinger lesion. You might pop up with a grade group 3 or 4 or 5 because that's what happens sometimes. And maybe you should get treatment. Otherwise, the short answer to you is that I just give warnings, like high volume, a high PSA density, family history. I warn you that you have a higher chance, as you said, of needing something done.
Totally. And, we'll talk about the kind of protocols that you guys have implemented there. And I'm sure even now, compared to when this started, protocolizing all of this based on any given number of features is challenging. It's hard to recommend a confirmatory biopsy in a 78-year-old who has a single core with small pattern 5, favorable density, no risk factors, to say, we got to get a confirmatory biopsy. And I mean, my practice would be, if I'm worried, quote unquote, the confirmatory biopsy comes sooner rather than later. And for the type of patient that you describe, I have to imagine you have this at the Hutch. One of the things that we really try to take advantage of is our multidisciplinary cancer clinic, where you basically get a baked-in second opinion. You get to meet it with the med-onc, meet with the rad-onc, hopefully hear things from a couple of different perspectives. And after that, if it's still like, I cannot move on without thinking about my grade group 1 prostate cancer, at least they've had a chance to hear things. I have my style of doctoring, but, it may not resonate with everybody. Well, sticking to grade group 1 disease, which I still think is interesting. It's not just like, let's discard this. It's real, right? It's real to the patient. And well, what do you quote patients, garden variety, the likelihood of something changing over the next 10, 15 years that you're going to have, maybe consider moving from monitoring to treatment?
If they look like the Canary patients, which were pretty diverse. I would say that, are we as high risk, in other words, a higher volume and maybe grade group 2 disease that at like Toronto? No. Are we as low risk as maybe the initial Hopkins cohort, which was usually only 1 or 2 cores? No. We're kind of in between. I mean, we have a lot of lower volume grade group 1 disease, and that's what I do see. Like 2 or 3 cores, 3 or 4 cores of grade group 1 out of 12 cores, let's say, with no lesions or anything like that. And I quote them exactly what's in the JAMA paper, which is about 50% treatment at 10 years, around 10 years. It's actually a little less than 10 years. And of those that get treated, there is, at relatively short follow-up, about a 10 to 15% recurrence rate, all right? And so I say out of 100 men that start like this, 50 of them are going to get treated by about 10 years. And it is true, of those 50 that get treated, there's probably going to be 10 or so that eventually have recurrence. And out of that 100, at least in our data, there's 1.5, I guess, that have metastatic disease at about the 10-year follow-up. So that's kind of the natural history of the disease as I see it. And our curves aren't that much different from Hopkins or UCSF or anything like that. I think Hopkins might have a slightly higher treatment rate because I think their trigger used to be number of cores, but now it's only by grade.
So as you're following these patients, the kind of tools in your toolkit, I always throw it out there. You have PSAs, you have MRIs, you have biopsies, you have rectal exams, maybe some secondary cancer screening tests, which are, probably exploratory. Am I missing any?
No, that's about right. So Canary is a protocol. So it's different because it's a study. And what do we do in real life? Because not all my patients are on the Canary study that have active surveillance. And there is can be a little bit of a disconnect, as you know. On clinical trials, you're required to do a biopsy at a certain time. It's not like something triggers it. So that's why I think that we're understanding the real disease, because we're required to do a biopsy, even if the PSA is still code normal, even if the MRI is totally normal. We do a biopsy anyway. So we know, I think, in some ways, ground truth. I think that uncovers truth, and we can get into that later as far as MRI and active surveillance. And we have actually formally assigned, said everybody that gets a biopsy needs an MRI before their biopsy. It didn't used to be that way. I think that's because the literature surrounding MRI is improving. I think radiologists are reading MRIs better. We're understanding the utility of the MRI better. We, as a group in Canary, have also looked at a variety of serum, urine, and tissue-based biomarkers. And again, I won't go through the data nor name them by name, but none of them have been game-changing. And we published on all of them. The most promising one, which I will name by name, is PHI, and we are studying that more under a guise of an NIH grant. And one of our young investigators, Claire Delacaille, just got a PCF-YIA to look more at that. So we are looking more at some of that marker, as well as we're in collaborations with an AI path company, AI radiology company, another transcriptomic tissue-based company. So we're pushing the envelope on that. But so far, as far as things that I could tell your listenership, as far as, oh yeah, you need to do this test, we haven't found something that's groundbreaking.
Perfect. And so generally, it sounds like reading the paper that, like when you're dipping your toe into something new, you're kind of nervous. You don't want to kind of miss something, miss the wolf in sheep's clothing. So it was a pretty intensive protocol, 3-month PSAs, and then fast forward 10 years and you're like, okay, we can maybe make this a little bit less intensive. So broad strokes, PSAs every 6 months. Or please, Dan, why don't you share?
Yeah. No, that's exactly right. We actually did an analysis. I think Cooperberg, Matt did the analysis where we looked at every 3-month PSAs versus skipping one. And then we figured, oh my gosh, we did do too many PSAs and people getting prostate specific anxiety instead of PSA. And they want to get them, having them have too much, they get live from PSA to PSA. So we said, yes, let's stop. Let's do every 6 months. And I think that's standard. I see patients once a year. We used to do DREs at every visit, and we used to do every visit every 6 months, and we reduced all that. I think we're de-intensifying, if you will, active surveillance a bit. And so PSA every 6 months, visit once a year, an MRI-informed biopsy, whether there's a lesion or not, an MRI-informed biopsy so we'll do one at the 1 year mark. And as I heard you say, if I'm a little more nervous, I might push it to 6 months, but I'm usually at 1 year, especially if I do the biopsy. But I get so many referrals that I sometimes wonder, and they're not MRI informed, so I'll do a biopsy sometimes at 6 months to a year for their first one. The next one at about year 3 or 4, and then every 3 or 4 years, but we also look at, of course, PSA and sometimes do an MRI in between.
That sounds right. Maybe a semantics thing. Are they technically starting surveillance after that confirmatory biopsy? Yes, no, does it matter?
I don't think it matters because 1 year in the scope of Great Group 1 disease doesn't matter. We, as a group on a study level, have been counting it, but at the time of diagnosis, we have. There are groups I know that don't start until the so-called confirmatory. We just call it biopsy 1.
Okay. I mean, I think that sounds, pretty much spot on. If you're nervous about something, everything kind of gets moved up the line, and you don't want to get a lay of the land before you go in poking and prodding. And I think patients kind of get that, understand that. How about, Doc, what can I do to decrease the risk of, requiring a prostatectomy or radiation or whatever?
Yeah, so that's a great question. We get that all the time. I mean, the simple answer is we don't know. Really, we've had a lot of studies. So Jonathan Wright here had an R01 based on, it's called Prostate Active Living Study, which is PALS. And he had patients do a kind of a diabetes diet type thing. If they were overweight, you could only get in if you're overweight. And then he actually sent them to exercise. And it was a randomized clinical trial looking at exercise and dietary changes in men on active surveillance. It was randomized to those that got it and those that didn't. The endpoint was scientific. It was things like insulin growth factor pathway things. But then there were things like weight loss and PSA and so forth, and they published that in Cancer. And there wasn't anything about less reclassification. It wasn't powered for that. My hunch, though, is if you look at some of the data from like the Physicians' Health Study and some of the other studies, that physical activity actually, seems to be some benefit in terms of even maybe prostate cancer recurrence in men that have had prostate cancer treatment. The bottom line is I don't know, and I don't see any benefit to recommending. I always say heart healthy diet and physical activity. Of course, it helps everything. It helps your cardiac health. It helps other cancers. It might help prostate cancer. And just editorially real quick, I actually did a study years ago where I actually fed men what we call a low glycemic load diet before their prostatectomy. And I did a cDNA gene microarray. This was back in the day. You could do that and publish a paper. And it showed changes in a short 6-week time frame of giving patients a lower glycemic load. It changed their gene expression profile dramatically. And it had biology. I mean, there was some biology there. I mean, lower proliferation rates and so forth. You could imagine if you did that instead of 6 weeks, you did it for 6 years, what that does to your body. Probably good things. But in the end of the day, I don't know. And I just say, hey, heart healthy diet, physical activity.
Makes good sense. When I was in Dallas, Yair Lotan had a curcumin study for men on active surveillance, and there's probably some evolutionary benefit. I always kiddingly tell patients that with my Indian diet, I probably get a fair dose of turmeric. We actually recently opened up the green tea extract study over here, and it's kind of similar. It's looking at, there's some inclusion criteria with Ki-67. What I find is patients love it. The whole process, whether it's surveillance or treatment, to be able to actively engage and not have stuff just done to you. So it's a plug. I mean, I'm not the overall PI, but we're happy to have it open here. It's been accruing like gangbusters, and neither here nor there, but to really accrue to some interventional trials is always nice.
Yeah. And I like what you said about, patient empowerment. I mean, I think that patients do like to feel like they're doing something for themselves. I can say again, as the last thing on that, we are what we eat, and we are doing something environmentally. We know the immigrant studies where you take particularly Asian men, in many cases it was Japanese that they looked at, who didn't really get aggressive prostate cancer. They got latent prostate cancer like anybody else. In Japan, when they immigrated to Hawaii and the U.S., they started getting prostate cancer at the same rates and same types of prostate cancer that the Caucasians did. We know there's something in our diet. We know that for sure. I always, like you say, that my parents are both from China, mainland. I was born in Ohio, and so I have kind of a Caucasian prostate in general. I know what my diet was growing up. I mean, my mom cooked a lot of Chinese food, but not nearly enough. So,
yeah, it's fascinating. I mean, it's a generalization. They're typically petite. Indians in America, their kids are a foot taller than their parents, and I don't think there's anything kind of genetic that transpired over one generation. All right, so grade group 1, I mean, it's the last question I have, and this is something I don't think I do a good job with, is transitioning off surveillance. Just, I can de-intensify it quite a bit, and maybe that's really it. But basically, telling a patient that the likelihood of this ever misbehaving is so small at this point that good luck and good night. If you start having bone pain or weight loss, give me a shout. What does this look like practically for you, Dan?
Yeah, great question. And that's actually a study question we're looking at now. And I can't give you all the details of the results because we're just looking at them and when people start transitioning off, because we start seeing biopsy having stopped. Because as you recall, I said on study, we say biopsies every 3 years, but then all of a sudden they stop getting biopsies. And then we look into that and we're like, oh, it's because they're 82, or oh, it's because they're sick with this, or they got another cancer or other things. And I think that just happens. When you look at the guidelines that are out there, at least that try to address it, they all talk about life expectancy. And as you said, when you get to a certain life expectancy, and that's usually 10-year life expectancy, sometimes it's definitely watchful waiting, which might not be anything at all, as you said, like waiting for symptoms. That's technically what watchful waiting would be, not even getting PSAs. We have seen, and we haven't had set a sort of criteria for this, although I'll say again, for practical reasons, I'll tell you what I do, which is when I transition people off, I'm still getting PSAs, or I'm having their primary care doc get PSAs. And I'll just tell them if it's getting up in the teens or something or more, then yeah, you probably should send them back, because I still have seen some benefit to either intermittent ADT and or radiation or something in older patients to avoid symptomatic issues like obstruction or bleeding or hematuria or so forth, or pain. And so I've transitioned to getting PSAs every year or two and no biopsies anymore, and or just sending them back to their primary care kind of on a practical level.
Totally. I mean, I think you can get information whether you do anything invasive or intervene. That can be a shared decision making, but I think patients kind of like it, is my sense. All right. Well, I think grade group 1 is still cool, still interesting, still worth chatting about. It's not like old news at all.
No.
Grade group 2, maybe the current star of the show, a lot of excitement about safely observing, baking in some of our newer tools in our toolkit, focal therapy, not to like totally get off kilter, but let's just say that maybe grade group 2 disease, there's more gray. Grade group 1, like you said, it's really a tough sell to pull the trigger to treat with just a biopsy showing grade group 1 disease. So grade group 2, now you've done their biopsy, you've looked at their MRI, taken all the factors that we've alluded to. Careful review of the path. What's kind of, helping sway that decision of we should maybe think about treatment now versus let's consider monitoring you or getting some more information before we make that decision?
I agree with you, first of all. It is kind of like that, a little bit more of the star of the show now, because we're trying to figure that out. We've already de-intensified treatment of grade group 1 to be surveillance, but now we have grade group 2 being on the guidelines as far as an option. It's an option. It doesn't say preferred, it just says that it's an option. So I'd say the easy place to start maybe is something you just said, which was review of pathology. And as you know, there's grade group 2 and there's grade group 2. And I actually literally draw a picture and I say, here's 3 plus 4. And that's because you have a primary and a secondary. And those numbers can be either a 3, 4, or 5. And I draw a picture of a piece of tissue and I draw a bunch of 3s and a couple 4s. And I say, yeah, this is a 3 plus 4. It's tight. And I show them a 4 plus 3. And then I say, it's just math. And remember, I'm in the world of Microsoft and Boeing, so a lot of engineers come to see me. And I say, it's just math. Again, 99% pattern 3 plus 1% pattern 4, that's a 3 plus 4. Or you can have 51% pattern 3, 49% pattern 4, that's a 3 plus 4. They are very different, all right? And I'll show them what percent pattern 4 they are. And if they're 5%, they you can literally see them just breathe a sigh of relief. If they're, 40% pattern 4, they're not happy. I'm not either, actually, because I think that's a real 3 plus 4. So that's number one, I look at percent pattern 4. Number two, our pathologists are reporting cribriform, and I think that's the next star on the block, and it should be the star now, because I think there's pretty good data showing that cribriform pattern 4 is the only relevant pattern 4. You can have pattern 4 that's non-cribriform that probably will never bother the patient. And so we look at if that pattern is present. And if so, how much? Because there's small and there's large and there's all these other variants. So just stay tuned, because that's going to be, I think, the next thing. My personal thing, again, side editorial, is that I think most of I don't know for sure, but one of my fellows, Mira Chapides, looked into this, is that a lot of the tissue-based genomics are finding they're really looking at cribriform as a high Decipher or a high Prolaris or a high. That's what they're seeing. They're not necessarily. It's nothing magical. In other words, it might be just pure histology. That's not been proven yet. Companies are going to kill me for hearing that. But the bottom line is that there's pattern 4 and there's pattern 4, and there's percent pattern 4 and there's high and low. And so I think on a pathology basis, I first review that. I do look at how many cores are involved, but as you know, it's changing a little bit, because there's transperineal and there's targeted cores, which you're only supposed to count multiple targeted cores as one core. But there's also this percent of the core involved to be favorable or non-favorable intermediate risk, and how do you do that with targeted cores that are a little more involved? And so I think it's a moving target to start out with, and then I'd love to hear your reflections on that. It's a big pathology review for me to start with, for sure, and all things being equal, PSA less than 10 and so forth.
Yeah, I couldn't agree more. I think there's a treasure trove of information. It's not necessarily overly glamorous per se, but pattern 4, I think that's a big one. I hopefully this is a biopsy in your hands where you feel pretty good that you sampled it, and if anything, sometimes that oversampling can potentially increase that. It's a small point. Number of cores involved. Sometimes I struggle with a reasonably healthy person. 7 cores, 50% core involvement, 5% pattern 4. I'm not worried, but I'm not totally casual about it either. I think those are some interesting cases. On the one end of the spectrum, and I do this even on the virtual visit, I'm holding my hands, let's say this is 10 millimeters. Here's how much is core, 80% is pattern 6. So it's this teeny tiny bit of pattern 4 that we're even having this conversation. So I do the exact same thing. I think intraductal is also something worth just kind of taking a look at. And while I'm thinking about it, perineural invasion still reported. Does that mean anything to you at all?
Yeah, so I'll tell you, this will give you an idea. We don't report it anymore. Okay, that'll give you an idea. We keep it in our database, but on an individual patient level, it's hard to figure that out. So yeah, sure, you get 100 people with perineural that are all equal to 100 men without, and yeah, the perineural might be a little bit worse outcomes slightly, but so slightly enough, at least in our look at the data, that we stopped reporting it because patients got all wigged out about it. Basically, they really want to know what's going on.
Yeah, well, that's kind of my sense, and I'm like, what does this mean? I'm like, what does it mean anything? Well, why is it on there? Well, I don't know. I wish it wasn't. So maybe I'll meet up with our GU pathologist and talk about this. There's so much to consider. Even if we've done the biopsy, we feel pretty good about it. I think that's a patient, if I'm considering surveillance, they're going to likely get a biopsy within a year. I'll just kind of throw it out there. Many of my patients that have grade group 2 disease are going to get some type of additional tumor-based testing. And that it can help sort out enrollment for clinical trials. We have the NRG trials. Should they be pursuing radiation to modulate ADT and second-generation ARSI? I think that's kind of nice. If we're not really thinking treatment quite yet, I think it can inform the timing of the confirmatory biopsy and either, again, raise or decrease the temperature a little bit for the anxious patient who's maybe more inclined towards treatment, who I think surveillance might be good. I think it's kind of nice. Less black and white, but I tend to agree with you. The intraductal, the cribriform, the high pattern 4, those are more ones where I'm like, we ought to think about treatment. The other ones, I'm pretty okay getting some information with maybe a provisional plan of surveillance before we do something? Sound okay?
I think that's great. Yeah, I mean, I can say that the sweet spot, I think, for additional genomic tests, the tissue-based tests particularly, is the 3+4, the grade group 2 disease, and or maybe high volume grade group 1. And this is not my idea. This is not a new idea. In fact, Scott Eggener was the first author of an ASCO guideline or ASCO consensus statement about genomic markers, saying that is an example of a great place maybe to use them. There are some uses to understand, yeah, as you said, length and duration or need for androgen deprivation with radiation therapy with some of the tests and some of the emerging tests, particularly the AI path test. So I think that there is some benefit for that group. I'll also say that, grade group 2, if you look at, and I always say, what do the randomized clinical trials show us? What do the case series show us? And then what can we tell from biology? Those are the things I always think about. And the randomized clinical trials that we have aren't very many, right? I mean, there's Pivot, Protect, and SPCG. And SPCG is really old, Scandinavian people, not very well screened. There's Pivot, which is kind of older vets. And there's the Protect, which is it's good. It's largely grade group 1. But when you look at those patients who are treated versus not treated in all those, because all those trials were no treatment versus treatment, particularly in the SPCG and the Pivot trial, the only group that benefited from treatment was intermediate risk. Now, maybe there were a lot of unfavorable intermediate risk, I don't know, particularly in the Scandinavian trial. But the only group that benefited from immediate treatment was the intermediate risk. The high risk didn't even benefit from getting treated right away. So it makes me pause in intermediate risk disease in general, even grade group 2, depending on how much, like as you just said, how much grade group 2 and so forth. It does make me pause a little bit.
Yeah, I appreciate that. I mean, it's easy enough to say we've gotten so much more sophisticated with MRI, but you got to kind of synthesize all of that and even Protect. It's potentially deferred treatment versus immediate treatment. And that's nuanced in and of itself. Young men, grade group 2, are they still candidates, or where does that kind of fall?
So first of all, they are, and to be brief, although I usually tell them probably what you tell them, which is probably not a matter of if you're going to need treatment, it's a matter of when.
Yeah.
Is it going to be 2025 or 2030, but it's not going to be never probably in a young man with grade group 2 disease. I do kind of inform them of that. If you look at, and we published this in the Journal of Urology, our group of grade group 2, and we do have probably the largest group of grade group 2 out there. We did show that for some reason. So first of all, the number of reclassifications in treatment look about the same between starting with grade group 1 versus starting with grade group 2. And you might find that surprising. You might say, well, going from grade group 2 to grade group 3 kind of sounds hard to do, but it happens. I mean, amazingly, it happens. But secondly, what we found is we've been looking and we've been really interested in understanding why people get treated after surveillance when there's no reclassification, when nothing changes. All right. And we published a couple of papers on it. One was in Cancer. The first author was Peter Kirk, and trying to look at quality of life or anxiety or what's driving people to get treated, even when their biopsies look the same, like grade group 1, grade group 1, grade group 1, get treatment. Why does that happen? What we did notice with grade group 2 is much more treatment without reclassification. In other words, men had grade group 2, got biopsy, same grade group 2, and it wasn't volume. They just decided to pull the trigger without any change. And we don't know why that is. But I tell patients who come in with grade group 2 that want to do after surveillance, I'll tell them, on the whole, you're a slightly higher risk of reclassification. And if we look at most men that come in with grade group 2, for some reason, they're getting treated more. And maybe that's because they're finding a little bit more volume or they're just getting nervous. I'm not sure. But it is, to me, it's one of those things that I always pause and show them the guidelines and say, it's an equal option whether to treat right away or not.
Yeah. There's data from Michigan that shows in men that get genomic classifiers, those that are higher risk end up getting treated. And you can take that data, I think, and kind of digest it however you want. What the truth and the appropriate next step, hopefully that'll be studied with some of the kind of studies coming through the pike. G major, G minor, always get those kind of twisted. But, it's like, all right, let's talk about it. Somebody comes in, 2-3 cores of grade group 2, 20% pattern 4, 50% core involvement. You get a gene expression classifier that comes at high risk. You rather say, well, let's biopsy you soon, or let's treat you. And I wonder if that's at least a part of the conversation or the driver. And maybe now, just like as we get cautiously a bit more comfortable with surveillance for grade group 2, we could say, hey, maybe we ought to biopsy you sooner, get some more information versus allow that to trigger us towards treatment. What do you think?
I think that we're, as you said, I completely agree. We're becoming just more comfortable with it. The whole idea of getting a biomarker, oftentimes that biomarker, by the way, is triggered by something else. It's triggered by an increase in PSA. It might be triggered by a MRI change in MRI lesion. There have been a couple studies by one notable group that showed that not getting a biomarker was protective. Now, why was that? Because they just didn't get a biomarker because the patient looked okay. I'm not kidding. It's published. And that was just looking at their case series and looking at all the guys that got a biomarker. That wasn't on a study like what we do a study. When Canary does a study, everybody gets a biomarker regardless of what's going on in their PSA or their clinical history. So I can see why it's kind of a self-fulfilling prophecy. If there's a reason why a clinician is getting a biomarker, there hopefully is a reason. In other words, the PSA is going up or something like that. And then they get a biomarker and it shows kind of high, and then the patient gets treated or gets a biopsy and they find worse disease because there is. And you see what I mean? And so it's an ascertainment bias issue, not a true biology issue.
One random thing I just wanted to pick your brain on for the grade group 2 patients, let's say they're higher risk on biomarker du jour. At our institution, they could go on to a clinical trial, NRG 010, NRG 10. Does that impact anything kind of on the surgery side, nodes, anything, or is that just we're going to treatment? My typical practice is for favorable intermediate risk to not do nodes or to do nodes or extended nodes, or like, is there anything that actually changes for you on the surgery side, I guess is the question.
It doesn't unless those little nuances, which I initially started with, I actually look at the cribriform thing. And because we've been tricked a little bit, I mean, it's not everybody anecdotally in my brain, but I should really look at our data. If someone has a high percent pattern 4, if they have a lot of cribriform, large cribriform, and again, they're 3+4, that we will do nodes more because, again, all the nomograms to decide whether to do a node dissection don't take that into account, okay? And so that's why it's a kind of, I always point to my head and say it's my own neural network in my head. But I don't do nodes on everybody, just like you don't. And although there are some that I do, and it's, again, based on those clinical factors, how many biopsies and so forth.
That's also like a hard thing to let go of. I feel like, as somebody who's kind of got our background in training, these days, like the easy is if they've got cancer real enough to go to surgery, they should get like some serious nodes checked out. And to back away from that is really, it's tough. And, we have visiting students give talks on how node dissections are basically not only not helpful, but potentially dangerous. And I'm like, gosh, what do I do? What do I do with that?
I mean, I was, because, you and I have the same training. I remember Peter Scardino saying almost the exact same words. If someone's got high enough or worse enough disease to be at my OR, I should assess their nodes. I mean, it was a little different. It was open, back then when we were in training, but now it's robotic and it's pretty well tolerated, although I think it's harder to get sometimes as clean of a node dissection takes a little longer and, 30 down or whatever. You got to do other maneuvers. And I had this thing, I think it was either Cooperberg or somebody called it NX regret. You take a prostate out, like, oh my gosh, it's T3B and I didn't do nodes and oh shoot, I wonder whether I'm going to miss a staging opportunity and not allow them to get maybe adjuvant, whatever. But there is a little bit of an extra regret that I've had, and we've all had it.
I remember when I started, our excellent surgical PA who bedside assist was like, do your nodes always take this long? And they literally took longer than the prostatectomy. Well, Dan, it's not lost on me that I get to sit around and have like super fun conversations about how prostate cancer is managed. And, we've got studies here. I love prostate cancer. I treat a lot of patients with prostate cancer, but the ability to do this really comes from the data that is fun, as you've said, to kind of generate. And there's also no shortage of challenges, grant funding, et cetera, that comes along with it. So I mean, personally, it's amazing to say, here's the data that comes from our neck of the woods and inform patients. And, so I benefit, my patients benefit. I want to thank you for that. And as we come across an hour, I'd love to hear your parting thoughts for patients, providers, trainees that may be listening in today.
Well, first of all, as a closing statement, I do also want to just thank you again on behalf of the SUO. I mean, I'm the current president, and this is an exciting launch to a great, hopefully years-long collaboration with BackTable. We really appreciate it. As far as, for people going forward, I always say, it's a life of inquiry, and we always are curious. And so all the fellows, as far as on a research level, it is hard work. But, Teddy Roosevelt said, doing hard work at work worth doing. And I think that we are really fortunate to be in a field where the work is worth doing for our patients, for each other, for our colleagues. And I think doing collaborative team science is the last thing I'll leave you with, which is, again, it takes a team. It's a village, we're just one side of many for most trials, just like you're running all those NRG and the green tea catechins. Everyone has to put their part in. And as a team, we're going to really make some progress, which we have in leaps and bounds, really, in my 20-year career so far. So I really appreciate it.
All right, Dan. Well, thank you again. I enjoyed it. I loved it. And, just like you said, looking forward to many more.
Thank you so much for listening. If you haven't already, make sure to follow, rate the podcast 5 stars, and share with a friend.
If you have any questions or comments, you can direct message us at _BackTable Uro on Instagram, X, or LinkedIn.
BackTable is hosted by Aditya Bagrodia
and Jose Silva.
Our audio team is led by Kieran Gannon, with support from
Aaron Bowles,
Josh McWhirter,
and Josh Spencer.
Design and digital marketing led by Brian Schmitz.
Social media and PR by Chi Ding.
Administrative support provided by Judy Dela Cruz.
Thanks again for listening, and see you next week.